Good afternoon. It's my pleasure to welcome you all to this activity. In fact, we have started this activity in partnership with the CIPLA Limited as a kind of masterclass, you see. So we'll hold it every month on different subjects of lung disease, and I'm sure you will enjoy it. It's not going to be a formal talk. You can, as a student teacher, you see, you can interrupt me anytime in between if you feel there is any issue or any clarification is required. Okay. Thank you. So today we have chosen the subject of spirometry and how to be an expert in understanding and doing spirometry. I think most of you will not be actually physically doing the procedure, which is largely done by technical people. But I think it is important to understand the I'm sure you must be also aware of spirometry details. Most of you are postgraduates, isn't it? Or some are anyway. So what is the spirometry is in a way a kind of pulmonary function test. Okay. So why is it important is to determine the best lung function for comparisons and future reference. It is a subclinical disease detection and for evaluation of treatment, because patient of asthma and COPD who are given treatment to know whether they are responding to treatment or not, and to predict the outcome, you see, that disease outcome, what is going to happen to a particular patient. So besides clinical history and physical examination, I think the lung function test, which is most important, is spirometry, you see. Intensive monitoring is also can be done of the patient disease, and of course it is also important and required for epidemiology and research activities. Now there are different lung functions, static and dynamic studies. Spirometry is the most common one, you see, which we are focusing on, and spirometry determines lung functions, lung volumes, capacities, flow volume loops, FRC measurement, and peak expiratory flow rate, you see. Then of course the other lung function test is airway resistance, compliance, and now forced oscillometry, which is relatively new introduction. And then there are tests for gas transfer like diffusion capacity and arterial blood gases. So all these tests have their own importance, but we are focusing on spirometry for this session, you see. Spirometry measures lung volumes, capacities, and flows, you see. I think these are the three most important things. And then you can draw with the help of knowing the volumes and the flows. You can measure you can draw the flow volume loop, etc. We'll come to those details later on, you see. I think this is just for the interest's sake, historical, you see. The first spirometer was in 1846 by this man Hutchinson, and initially it was it kind of you see advocated for the diagnosis and treatment of tuberculosis, because at that time, you see, in the entire Europe and perhaps the whole world, tuberculosis was the main disease which was kind of posing a threat to everyone. However, in due course of time, tuberculosis went into the background because it was not found to be really useful for tuberculosis. Initially, they had thought the lung volumes would be help in knowing about tuberculosis, the activity, etc. But those things, of course, now they are not really important. This is his first paper or the first data which was published. You can see here that what he says that it was done in sailors, fire brigade people, different kind of people. You see, this man was doing spirometry, and due course of time, of course, it was adopted in different hospitals, you see. This was the first one. You can see here is the what we call as the double bell spirometer. You see, most of you would not have seen it and perhaps will never see it. You see, we worked with this spirometer for long, almost 40 years ago. You see, now of course we have all computerized kind of instruments. You see. Now, how to do spirometry? The patient is made to sit or stand. The procedure is explained to the patient. The tight clothing is removed because the patient cannot really comfortably breathe. He should sit straight. Nose clips are generally recommended because otherwise some leakage would occur through the nose, and the lips are tightly sealed over the mouthpiece. One begins with a tidal breathing. You see, the patient is asked to breathe normally. And then, of course, afterwards, the patient is asked to take a deep breath, which is slow but not forced, no breath holding. At end expiration, he is asked to perform a maximum inspiration. Have you visited pulmonary function laboratory? Any one of you? So there the technician, you see, he asks them to take a deep breath to the total lung capacity, as much as he can, you see, and then exhale as hard and as fast as possible. You see, that is the idea, to exhale as hard and as fast as completely as possible, because that's what we are measuring, the forced vital capacity. You see. And the information obtained from spirometry are the volumes and capacities, flows I have already said. And then another important thing is bronchodilator reversibility. You see, that is done, for example, to differentiate between asthma and COPD, etc. And then you can draw volume time and flow volume curves. You see, these are, of course, will come to the curves soon. The volume time curve is the most original curve, you see, which is drawn directly by the old bell type spirometer. The bell type I showed you, where you see what was done earlier was there's a water tank, and above this was a bell. You see, so it used to, once the patient was breathing, so that it used to displace water, and that's how. Maximum amount of air which can be inhaled, and then patient is asked to exhale as fast, and he will exhale to this level, you see. So that is the vital capacity. Okay, and what is left in the lung at this stage is the residual volume, you see. Okay, so then of course you can calculate the other parameters. So once we know the vital capacity, and we can calculate these volumes from this. However, you cannot calculate the values below the type of vital capacity. You see. What are these? Residual volume, and then FRC, you see, and also TLC. So these are the values which you cannot really calculate from spirometry, you see, alone. That is what is a kind of what is we call a dynamic lung volume, or the forced exhalation, you see. Here the patient is asked to kind of prolong it, the forcefully exhale, you see, and the drum is rotating. In the past it was the drum which was rotating, you see, where the marking was done. Now of course everything is electronic, so that the it is either but the problem with electronic spirometer and all electronic instruments is that they don't really tell you the actual mechanism or things lying behind. They will give you the final result, which is okay. Okay, so that tells the time. This is the time, and that is the volume exhaled, you see. So that is the max forced vital capacity. And from this graph, you can calculate flow at any volume. See, that will form the basis of our flow volume loop. It shows only, for example, FEV1. What is FEV1? At 1 second. But you can also have FEV2, FEV3, 4, 5, 6, you see. So that's what is the, you can calculate the volume at different flows at different volumes, and then you can draw a kind of a curve with that. That is what is called as flow volume loop, you see. Then there is another thing like peak expiratory flow rate. What is peak expiratory flow? Is a maximum flow that can be generated by a forced expiratory effort following deep inspiration, and which can be maintained for at least 10 milliseconds, you see. Peak expiratory flow rate originally was calculated from the spirometry itself, you see, the peak, the top of the curve. However, in the due course of time, a separate instrument was invented, so that you must have seen, all of you see, because that peak flow meter is used for even home monitoring and other things. So, but it is only a monitoring tool. Peak expiratory flow should never be used as a diagnostic kind of test, you see. You know, this is what is the kind of peak flow with spirometer. Then that instrument, of course, you must have seen different kinds are available these days. And then we come to the flow volume curves, which I was already discussed. Told you that here what is done is the flow volume curve is derived from the volume time curve itself. You see, that is, I think, important to understand. Here the x-axis shows the volume and the y-axis the flow. Okay. And from this, of course, you can calculate these parameters like FVC, FE1, we have already talked about, and this is a normal spirogram, flow volume time, flow and volume, which is is a kind of static measurement, you see. This is just for interest sake. I think these were the type, this is how we used to do it, you see, from the inspiratory curve here and the expiratory and inspiratory curve, and at different, you could with hand, I had some of these old diagrams, so I just, for our own interest, copied it. But it is important is to say here that it is not necessary to have the computerized instrument. You can always draw these things from the standard graph, volume time graph. What are these are the assessments for test quality, because in fact spirometry is one of the most kind of erratic test which is done in the laboratories, routine laboratories, and is most wrongly interpreted, unlike all other tests, you see, because there are so many variations here which has never really looked for. The ATS, the American Thoracic Society, has laid down several criteria which should be fulfilled for a satisfactory spirometry. There should be full inhalation prior to start of test, satisfactory start of exhalation, which should be fast start, you see, so that the first 150 ml should not be leaked, or more than 5% of forced vital capacity. It should be free from artifacts, cough, glottis closure, abrupt ending, variable effort. All these are very common errors while performing spirometry. You see, people may cough, or there is a glottis closure which people feel suffocated and so on. And these always, these things will affect the results of spirometry. Normally it should be a satisfactory duration, that it should be minimum 6 seconds, you see. I showed you the earlier, so that the expiratory graph must be for at least 6 seconds, you see. It should be, so this is acceptable graph, and then it should be reproducible. Reproducible, the same should be repeated in the second or third attempt as well. So for many times 3 to 8 maneuvers may be required. And the two largest values for vital capacity and FE1 should be within 0.2 liters. So only then you should take. And if these criteria are not met because patient may be diseased, not able to perform so many efforts, so then interpret the 3 best results, okay, and report the highest FE1 FVC from acceptable trials. And ideally there should be no more than 5% variability in different tests, you see there. So to have the better quality, one should ensure that the instrument meets standards for accuracy and precision, and it is maintained and calibrated daily, you see, on schedule. Procedural standards are followed. So this is very important to do a good spirometry for a kind of meaningful interpretation. Okay, so that is the general for spirometry. Now we'll which is mostly your work as a doctor, that how to really interpret spirometry. What is normal for spirometry? There are the hundreds of papers on this issue as well only, that what is normal. Commonly we use predicted normal. So percentage of predicted, isn't it? We always say 70% of predicted or 60% of predicted. So predicted, the problem here is prediction is that it is number one, it is age group specific, and then it is derived from regression models, you see. Regression models, because spirometry depends upon, can you tell what are the factors on which spirometric values will depend upon, you see? One is age. Ethnicity is also important, and not only, I mean, for example, to have a normal value for this country means that you must have for different regions, you see, north, south, east, and so many things. So for people, so it is besides the factors like age, height, and weight, which are very important, it also depends upon ethnicity. So prediction equations obviously would depend upon the different regions, so every laboratory, they say, ideally should have its own prediction equation, you see, which is very difficult generally, because to have normal prediction equations, you have to have a large data of normal people, several hundred people. So that is not always possible. Sometimes, of course, we go by the personal best in a person, for example, in asthma or COPD, if you are following treatment, you see, then if you have the baseline and then following treatment, you see, so 1, 2, 3, or 2 weeks, 4 weeks, 6 weeks, etc. So that is what is his best. That is then you will calculate the percentage of that predicted. Okay. Then second is to follow the lower limit of normal, LLN, what we call as that you fixed values. You see, that is not commonly done. For example, if it is less than 70% or less than 65%, it is abnormal. We can say that, you see. Or many people will say it is lower 5th percentile or 95th percent confidence intervals and so on. So there are different kind of ways of expression. But these are the two most commonly kind of parameters which we use, that either we call percentage of predicted or less than or more than lower limit of normal. The problem with the LLN is that is one is it is variable, and then we do not know what is abnormal. For example, computers, all these instruments, even if it is, for example, rather than is something 3.5 liters, if vital capacity is 3.5 liters, if it is showing 3.49, it will say abnormal, you see. So that is the problem with these things. So one has to be very careful for all these things. And then another important thing these days is that there are many computers which kind of calculate so many values. You must have seen reports, you see, they will, because it is just a calculation, all, they only cause confusion, isn't it? They do not really tell us anything. Do not use more than few such variables. Increasing the number of variables increases the number of false positive results, you see. What we see in most cases is the vital capacity, FEV1 and FEV1 over VC ratio, you see. And it is suffice to provide information which we need most of the time. So that is what is vital, FEV1, maximum volume of gas which can be expired in the first second of forced expiration, okay, from a position of full inspiration. And it decreases in COPD and other obstructive disease, as well as in restrictive disease, it can go down sometime. FVC is the maximum volume of gas which can be expired from the lungs during a forced and complete expiration. Okay, and then ratio, of course, is the ratio between the two. Another important sometimes is also the 25-75%, you see, FEF. What is FEF 25%, 75%? Is the forced expiratory flow over the middle half of the curve, you see, which you have seen the curve earlier. So the middle of the curve, the flow during that is the FEF 25 to 75%. Some people also say FEF 50%. You see, there are also nowadays some people say that it is the most, there are sufficient number of papers who will say the FEF 25% is very, rather than FEV1, it is the FEF 25% which is more sensitive, you see. But those kind of, these are research questions which we, for the time being, do not really take into clinical interpretation. FEET is the forced exhalation time, the time for which forceful expiration or exhalation has been done. And that will be prolonged in COPD as well as in asthma. In all obstructive disease, it would be prolonged. The only thing is in asthma, it is reversible, so it may not be so all the time. And then, of course, we have already talked about is the peak expiratory flow rate, which is the maximum of the peak of expiratory flow. Okay, and that can, of course, be measured independently also with the peak flow meters or breathometers, so far. So in summary, the guidelines for interpretation is first you evaluate the test quality, then you use FVC, FEV1 and FV ratio as primary guides. Choose statistically valid lower limits of normal. That is what, either you choose the LLN or you choose the percent predicted. You see, percent predicted, if you have your own equations or if you know the person's best, you see, then it is easier to use that. Interpret values well above or well below lower limits of normal with confidence. You see, there we were just discussing that it should have a, for example, confidence, 95% confidence or 90% confidence. You see, at what level is abnormality seen? Because all abnormalities, even if it is 99%, it doesn't mean abnormal. You should be at least 2 standard deviation below the LLN. You see, that's what we normally consider clinically significant. You see. So that is what how to proceed. First, you see the FE1 over VC ratio and see if it is normal or reduced. If it is normal, then you check the vital capacity. If vital capacity is also normal, then everything is normal. You see, patient is normal spirometry. If vital capacity is reduced, that indicates a restrictive defect, you see. And based on the vital capacity, it can be categorized, the mild, moderate, severe, as well as, because restriction can be because of hundreds of reasons, you see, whether it is a kind of pleural, or it is a chest wall, or it is a lung. It doesn't many times, for example, suggest interstitial lung disease. That is the very common kind of report which I see in the computerized reports. That is a very erratic thing to say, you see, because restriction, even if you don't exhale properly, it will show restriction. That is a very common issue, especially in older people, you see. They won't be able to exhale properly. So that only show restriction. So that does not mean it is a poor effort, okay, poor cooperation. That also would restrict the vital capacity. So this should be interpreted very carefully. So all restrictive defects on spirometry, in fact, should be corroborated with clinical findings or with other tests, you see, ECG, so, and as well as the chest X-ray, CT scan, and so on. However, if FEV1 over vital, this ratio is also reduced, then you check the FEV1. If it is also reduced, then it is obstructive defect, and that is a relatively more kind of confidently diagnosed thing, you see. What are the limitations of interpretation? The statistical estimates may not represent true patient status. False positive and false negative results are very common. Mixed defects are always a problem. They would be there, including in, for example, you can see the mixed defect on spirometry even in emphysema or even in pure interstitial lung disease. So that is not uncommon. Borderline values again are some problems, and arbitrary categorization of severity, you see, because you may diagnose a patient as very severe at a point of time, but if you do the next day, the spirometric values, especially the obstructive defect, may change, you see. So to categorize severity based on the spirometry alone is sometimes fallacious. Now, these are some of the examples which I like to discuss, and maybe you can help solve this. This is a patient, 50-year-old man, lung cancer. His vital capacity is 3.5 liter, inspiratory capacity 2.2 liters, and tidal volume 0.5 liters. What other values can be calculated from this? Anyone? IRV, yes, IRV is inspiratory reserve volume, can be calculated. What else? On which values cannot be calculated? That we have already discussed. Residual volume, FRC, as well as TLC. Okay? And this is the FRC calculated by a different method, because it cannot be calculated by spirometry alone. See. So that is 3 liters. And then you can calculate RV and total lung capacity. And the third question is, what is expected VC after a left pneumonectomy? Is a patient of, we'll try to solve some of these. So this is the graph which I had shown earlier. You again focus here so that you have already answered correctly. IRV and ERV, they can be calculated if you know the vital capacity and you know the inspiratory capacity was okay. But these things below this cannot be calculated. So that is the, in a way, what other values can we, we've already said that vital capacity, ERV and IRV, okay? And these values cannot be calculated. This of just the calculation which has been done. So once you know the FRC, then you can calculate all these parameters as well, residual volume and total lung capacity. And after a left pneumonectomy, what do you expect in this patient? Well, theoretically, if you remove one lung, you are removing half of the capacity, and the left lung volume is more. But there are plenty, of course, it is not necessary, because what happens is that if you remove the lung, the other lung will expand, you see, and compensate. So there are a kind of different studies also. They say, for example, at 3 months or 6 months, if you do spirometry, there would be loss of about 1/3 of vital capacity. Not 50% or 55%. It is only a theoretical loss of 55%, but in due course of time, in months, it is not more than 30% or 25% if you really do good exercise and other thing. Now here is another, of course, 58-year-old smoker with V's. These are the observed values, and these are the predicted values. Okay, so what we can see here, this is reduced, this is also reduced, and this is also reduced. So what is this? So reduced, reduced, reduced. All three are reduced. What is this? So obstructive defect, okay. Because in of course, obstructive defect, the total vital capacity as well as the total, the vital capacity in particular will also be reduced. So some people will try to say it is a mixed defect. It is not so, because in emphysema or COPD, when it is severe, especially, vital capacity is bound to be reduced, you see. So that doesn't, so it is only obstructive defect. And then, of course, here it is the observed parameters and predicted. And these are normal, isn't it? Both vital capacity and FE1 are normal. And what about the FE1 over VC ratio? I think there is I think these ratios perhaps are not calculated properly, but you can see here that they're reduced, you see. So this is also reduced. Okay, this is the predicted reference value. So these are reduced, and this is normal. So it is a sorry. Restrictive defect. Okay. So this is the flow volume loop, which you can draw. Not only the, so this is a tidal breathing. You can also have this, the full inspiratory and expiratory. Now this is the normal, and this is the expiration. Patient is asked to exhale and then inhales, you see. Okay. And that is the peak flow, peak expiratory flow. So this is the effort independent flow during expiration, but there's a full inspiration and vital capacity. So all these parameters can also be drawn from the loop, you see. So this is the abnormal loop. The advantage of drawing a loop here is because it is more dynamic. Earlier one used to use only the spirometry graph. Now we always use the loop because that gives, number one, both inspiratory and expiratory kind of flows. And the mere shape of this loop can tell you the disease, you see, of course. And here, for example, it is a miniaturized version of the normal loop, you see. And the expirate, this is the expiration graph. You know that the above is the expiratory graph, and below the line is the inspiratory graph. So this is, of course, reduced, and this is also reduced. So this is obstruction. And this is restriction. Restriction, the graph is always a miniaturized version of the normal graph. That's what is there. So anyway, this is, for example, again from the old kind of, what will this suggest to you? Fixed obstruction, where? Expirate both. Expirate. So what is a fixed obstruction seen in which clinical condition you would suggest? tracheal stenosis is the most common, you see, following tracheostomy, etc. Tracheal stenosis would develop, but otherwise tumors and so many things can be there. And this shows the inspiratory graph only is reduced here. All right, so now just last few slides I have. What are the practical difficulties faced to perform PFTs? One, of course, is the availability itself, you see. Nowadays, of course, it has become relatively freely available, but still the problems are there, because just having spirometer does not mean having a good kind of test in your hands. I have already said you see the poor quality, unvalidated spirometers, and then of course poorly trained technician. That is also important, because if you do not really get a sufficient effort on the part of the patient, then most of the time it would be restrictive, isn't it? Restrictive parameter, and that is one of the most common diagnoses made. And if you really go into the literature, you will find that one should never rely on the presence of a restrictive defect based on spirometry alone, you see, because that would depend upon the laboratory to laboratory. So again, showing the same thing, that for example, if a patient A has symptoms, and if he's seen by a family physician, and you suggest kind of suspect obstructive airway disease, and history taking only, if there is no spirometer available, he will give oral bronchodilators based on this. Is a very common practice, but symptoms may worsen, and then he goes to a chest physician who also suspects obstructive airway disease, but there is no time available, skill spirometry is not there, etc., extra heavy OPD, or other errors, you see, improperly fitted mouthpiece and ill-trained staff, as we have discussed, poor performance. So again, the picture remains the same. So there are so many errors here, you see, you can see in making a diagnosis of obstructive airway disease or any practically disease based on spirometry alone. Now lastly is a few words on spirometers instrument itself. Initially, these were the volume measurement devices which I was showing you earlier, wet and dry spirometers. The wet were on a water tank, so just reverse the bell and see the displacement. They were also called as displacement spirometry, you see. Actually, these are no more available and not used. And the others are flow measurement devices which are using either a pneumotachograph, mass flow meters, or ultrasonic, etc. There's so many kind of different electronic instruments have become available. Here the volume is calculated by integration over time. I'll just show you. So these are the volume spirometers. They measure volume directly, easy to use, but no longer produced, you see. And then of course bronchodilator, I think it should come early, but bronchodilator reversibility, how will you test this thing? That you know bronchodilator used for 4 hours, baseline spirometry is done, 2 puffs of salbutamol, and the repeat spirometry after 15 to 30 minutes, you see. And if there is increase in FEV1 and or VC more than 12% and 200 ml, that would means reversibility. You can see here that that kind of, this was the before, sorry, this is the yellow one is the before, and then after bronchodilator administration, you can see there is improvement in the loop, you see, and that clearly shows the bronchodilator reversibility. These we have partly discussed. Most frequent mistakes is cough during the procedure, glottis closure, preceding inspiration is not maximum. Patient may kind of stop taking inhalation. Leaks can occur from mouth, apparatus, nose, etc. hesitation during start, that will also alter the values, and abrupt ending, that will also alter the value. These were some of the common mistakes, poor performance, leaks here you see, etc. And then here is the early termination, as you can see. I think this is what shows the abrupt ending. For example, if the patient has terminated here early, so the values are going to be poor, you see. Same is true here. FEF too late, and thus sub-maximum also. This is the normal, and this should be the blue one is the normal, but this is what is the patient's performance. So it is a kind of sub-maximal effort, you see. Here preceding inspiration is sub-maximum, so he has not inspired to the full. Okay. Like he should have inspired to this level, but he has expired only up to this level. So some maximum inspiration and so poor values. And this is again the problem that cough, perhaps you see. Cough during maneuver, you can see here the types of cough on. Abrupt ending. So there can be obstructed mouthpiece, glottis closure, and so many things you see. All right. Then is lastly the question of portable spirometers. The conventional office spirometers, they are also bulky, costly spirometry devices. These are costly spirometry devices and complex interpretation. See, the software perhaps may be complex. So especially for primary care physicians, now there is advocacy of small kind of portable instruments which can be used, small devices, low power consumption, low cost, and handheld instruments are there. Discussed earlier, they can be either pneumotach, when there is a here it's a transducer which kind of measures the pressure on both sides, and that is the pressure difference on either side of the central mesh, that is the mesh you see. It gives a signal and it reflects the flows. So it converts the pressure difference into the flow, you see, and that is what is a pneumotach. And most of the handheld instruments, the portable instruments, are using pneumotach technology. It could be a turbine technology which is more robust, where it has the blades, and when the air passes through these blades, they rotate, and the rotational movements is translated proportionally into the flow. This is the CIPLA introduction, the Spirofy pneumotach, which is a flow sensing spirometer. It is the most commonly used technology to measure, as I said, portable wireless spirometer, 2 meshes, and correctly detects flow in 97% of cases. You see, they say it is a very useful tool for airway obstruction, and so it is advantage. Most important is that it is a handheld instrument. So finally, what is the indication for spirometry? It is to diagnose or evaluate the signs and symptoms and impact of lung disease on pulmonary function, screening of patients at risk, and monitoring therapy, which we have discussed earlier, estimation of disability and impairment. In fact, now it is an important function of spirometry, you see, especially patients. If we ask for disability, orthopedic disability is always assessed. In this country, of course, it has not yet become popular. But for disability assessment, for compensation by insurance companies, as well as compensation by employers, by governments, they would like to know how much is the disability. So outside this country, this heavily relied upon investigation, you see. But perhaps there are no norms for so far in this country that what is the level of disability. But it is very important use, you see, to estimate the disability and impairment. And of course, in public health, it can be used for epidemiological studies, you see. FE1, they say it's a normal reduction, decline occurs over the year, for example, it is normally it is about 26 ml per year, but it would be variable, so 25 to 30 ml, and depending upon the other conditions, it would be variable, and smokers it would be more. So the decline is very important, you see, that's what we discussed earlier, that the spirometric values are normally dependent upon the age as well. I think we can stop. As I already said, that you can classify severity based on these parameters, and the GOLD, you know, the Global Initiative for Obstructive Lung Disease, they have based on these values of predicted, they use always most of the time it is the predicted values which are used as normal references. So how to maintain hygiene of the spirometer? One is that the disposable mouthpiece, because that of course is directly put into the mouth, and then other indirect either you can use the filter, the line, the kind of tubing system, etc. All these things are potential sources of infection. And in case of infections, tuberculosis, hemoptysis, bleeding mucosa, acute airway infection, and compromised immunity, one should be cautious in doing spirometry, you see, because it can transmit infection. Although there are studies that no evidence that routine spirometry testing poses an increased risk of infection to immunocompromised patient. But I think it is always best to avoid in an active infection, tuberculosis, and so on. What are the complications? It is a non-invasive procedure, so the risk is minimal, but still patient has to exhale with force. So there can be dizziness, feeling short of breath, coughing, sometimes asthma attack can get precipitated. And inaccurate results, the degree of patient cooperation and effort. I have been asked more and more, use of bronchodilators. You see, if you do not stop the use of bronchodilator, that also would affect the, ideally you should stop bronchodilators before doing spirometry. Then other kind of conditions can also alter the results, you see. It is contraindicated absolutely when there is hemodynamic instability, in shock, recent myocardial infarction, acute coronary syndrome, acute respiratory infection, pneumothorax, pulmonary embolism, growing or large aneurysm of thoracic aorta, because in a way it increases the intrathoracic pressure, you see, when you, so obviously all these conditions, you see, where the increase in pressure is important, so they should be control, like retinal detachment also, you see. And these are of course relative contraindications that who cannot be instructed to use the device properly yet. Facial pain and so on. So I think these can be taken care of, but these must be kind of, one should be cautious and avoid it. Okay, that's all I wanted to say. If there is any question, I'll be happy to answer. Yes. ठीक है, then I think we can. वो कोई बाहर से तो नहीं है कोई, because this is being projected at multiple centers in the country, so
say grade 1 or 2. So how do they deal with such patients? Their ratio will be normal, FVCPM will be normal, that there will be small airway obstruction. So how do you deal with these patients?
Yeah, I think the only indication for small airway obstruction is from FVF 25% to 75%. But small airways is a problem. That's why there are separate. For example, initially they used to have the closing capacity, closing volumes, and or you know the airway resistance. You see, especially the dynamic airway resistance. So you have to finally document that there is small airway, early small airway obstruction, because later on, of course, the spirometry may become abnormal. Otherwise, the closing capacity and closing volume were the most initially used. I'm sure you must have seen that graph. You see the nitrogen washout technique. You see it used to employ, and one can measure. You see, you're shown where there are phase 1, 2, 3, 4. So that is one of the nitrogen washout technique. You can use that. Or nowadays, of course, people are also using the FOT, the forced oscillation technique. You see, which we'll discuss in a subsequent session. FOT is becoming more and more popular now in place of spirometry, because that can be done without any effort by small children, by older people, etc. And it uses a different principle, you see. So FOT or the impulse oscillometry, you see that.
So my question is, how will you manage such patients in OPD? Will you go in with a line of COPD management, or will you wait till that spirometry? I just want to know.
Well, yes, it depends upon the symptoms, and ideally one is for example, to see the risk factor. You see, if it is a smoker, then you should stop it. You may have to use bronchodilators like COPD, some degree, if you really document it. You see, but that would depend upon the symptomatology. You see. Well, this of course is a question that what is your take on Cipla's indigenous portable spirometer device, Spirofy, you see? Well, I will say it is a good portable instrument, you see, for routine use, especially by the GPs, and for the field use. It is a validated instrument, and it is also for all the values. You see, it kind of conforms to the ETS standards. However, for respiratory labs in general, I will say one should have more detailed and kind of solid or robust instrument. This is a very good portable handheld instrument, which is for routine measurements. It is and it is a validated one. I think that is most important. It's cheap as well, and indigenous, of course. What is the difference between pneumotachometer and a spirometer? Well, spirometer, of course, are multiple types, as I said, that volume spirometers, which are not routinely used, but pneumotachometer is the kind of transducer which most of the spirometers employ, you see. But the spirometer can also use turbine kind of transducer. So, but otherwise pneumotachometer it is a transducer which measures the pressure differential and on both sides of the mesh, and that is converted into the flow signal. So it is a pneumotachometer is a good technology which most of the handheld instruments in particular employ. Is there a difference in reading between different technologies, spirometers like windmill spirometer and pneumotach spirometer? I have already said about these things, but the actual values between different spirometers should not vary much. I think that the difference is only of the convenience, size of the instrument, the cost and other factors, you see. But the actual value of a patient should not vary much, and this has been validated in several studies. Otherwise, the instrument, because the standard still is the volume displacement spirometer, you see. That forms the gold standard, because that is a basic principle which you cannot really go against. That there is a water, you put bell over it, you exhale in it. The displacement of the bell indicates the volume of the air which has been exhaled. So that is a standard. But most of the, because these are the, whether it is a pneumotach or windmill or the turbines, spirometers, they derive values obliquely from equations, isn't it? For example, from the pressure difference. So it is not a directly measured value in that sense, but these are the most common. The other ones are not really used nowadays. For example, even if you, for calibration of spirometry, what do we do? Is to use a syringe, 300 ml syringe, you see, which, so that is also a volume displacement, okay? You push this syringe as well, so, and you measure the difference on the pneumotachograph, whether it is a same signal is generated or not. You see. How to diagnose ACOS, asthma overlap syndrome, so, on spirometry? I think that is a the ACOS is a kind of tricky diagnosis these days, and nowadays people say it is not even ACOS, it is ACO, that's all you see. And that is more diagnosed on the basis of history, and spirometry is only helpful. The overall diagnosis cannot be made on spirometry alone. You have to go into the back history. If history is just of asthma, patient is a smoker now, and there is a, by and large, the spirometric values will show either the mixed defect or primarily the obstructive defect, you see. So, but from single or even multiple values of spirometry alone, one cannot make a correct diagnosis of ACOS. Okay. Anything else? और तो नहीं है बस. Okay then, thank you very much, for your patience. Thank you. Thank you.